Okay, now we can start. Good evening and welcome to today's discussion. Today we'll be talking about hemodialysis and some of the major modalities of renal replacement therapy. But we'll be focusing on hemodialysis for today, and then maybe subsequently we'll discuss peritoneal dialysis. Uh, we are hoping that we'll be able to discuss, the principles that are guiding this, indications, contraindications, complications, and I'll try to make it as simple as possible. Where necessary, I will include, illustrations, videos, so that you have a better understanding, right? So, before we delve into hemodialysis, we need to talk about what exactly is, RRT. Does anyone have an idea of what RRT is? Does anyone have an idea of what RRT means? I want it to be a back and forth. Like we should be able to have a conversation. So, what's the meaning of RRT? You can see it on the screen. RRT. What's the meaning? This one. What does it mean? When you see RRT in relation to um, nephrology, what does it mean? Yeah, it means renal replacement therapy. Dr. Kauta, you are correct. So, whenever you see RRT in relation to nephrology, it means renal replacement therapy. So when we talk about renal replacement therapy, we are talking about other things that we can do or other means of taking care of the kidneys when they have failed, right? Remember, there was a time that we discussed one of our topics was chronic kidney disease, right? I think see it here, so you can go there and read it. I also had a video on that particular topic. So um, it means that when you talk about chronic kidney disease, you have to talk about the staging, right? So it gets to a point from stage one, stage two, stage three, stage four, and each one is dependent on the estimated glomerular filtration rate of the patient, right? So it gets to a point where what we call end stage renal disease, that's when it's below equal to or below 15, right? When the EGFR of a patient is below 15. So we say it is end stage renal disease, that's ESRD. So when that happens, in fact, before that happens, you're already preempting it, you're already planning. Like when a patient is in stage three, you know, you are planning already that this patient, this patient is going to get to stage five because CKD is progressive. The patient is going to get stage five. So the patient is in stage 3B, you're already planning on how you're going to tackle this situation. So you will most likely start planning towards renal replacement therapy, which can be divided into either dialysis or kidney transplants. Now, for most people, because the kidney has failed and you are not going to be doing the transplant immediately, even in developed countries, it's not like you just wake up one day and just go and do a transplant. Then there needs to be proper planning. You need to even get the organ donor, whether you know, dead or alive. Maybe some patients can be in vegetative states and they have already signed documents that they release their organs. And then there has to be a match between the organs, relatively. Even though you still need to use immunosuppressants after doing kidney transplant, though kidney transplant is a topic on its own. So we'll take that on a different day. But I'm just giving you a broad overview of what renal replacement therapy means. Okay, so eventually you do the transplant. But before you do that transplant, most times you are going to be doing a dialysis. Okay. And the commonest type of dialysis we do for adults is hemodialysis. The commonest type of dialysis that we prefer for children is peritoneal dialysis, right? So these are the subtle differences. So let's talk about hemodialysis for today. Now, for you to do a hemodialysis, some of these things that are on the outline are actually the requirements. Okay, so you need a vascular access. Usually, they use a large vessel, usually on the arm. There's something they start creating that vascular access. they create an arteriovenous fistula, like an artificial arteriovenous AVF, right? Arteriovenous fistula, just to be able to, have a large vessel that can contain, because it's just as if you're removing the patient's entire blood, you're passing it through a machine, and you are purifying the blood through the machine. Just that machine is basically performing the function of the kidney. The function of the kidney is to remove waste products, right? uh And then excrete them as urine, and return the blood back as normal, clean, waste product free blood. Okay, so that's the same thing that that machine is going to be doing. Now, for that machine to occur, to work well, the blood needs to come out of the patient, right? So you need a large vascular access. Sometimes they use the femoral vessels. They use you know, other vessels on the forearm, right? So then when it leaves the body, it gets passes through a lot of tubes, and it gets to the dialyzer. Okay, so dialyzer, we'll still talk about it. Then there's the dialysis machine itself, okay, which will now do that work of purifying. Has anybody seen this thing done? Then when you do this, there are complications. There are complications that can arise. Before you even do this, there are indications, there are reasons why you need to do this. Then when you finally do it, there are contraindications. There are complications that can arise, and there are contraindications. There are reasons why you should not do hemodialysis. So let's proceed with the topic. So this is standard definition. Modalities of treatment designed to substitute or replace kidney function, usually employed when the kidney fail or are unable to perform their functions optimally. So these are some of the reasons why you have to do a renal replacement therapy. Renal replacement therapy is a broad term. So you have acute kidney injury, chronic kidney disease, drug poisoning, lactic acidosis, refractory edema, all this. So I'm not going to be delving into all these graphs and epidemiology, okay? But like, if you start checking the people that actually do the hemodialysis, okay, most times people do hemodialysis. 70% of people do hemodialysis. 22% of people do kidney transplant, and then 8% do peritoneal dialysis. In Africa, only less than 5% are going to do renal replacement therapy. One is that they have to pay out of pocket. Have you seen the price of dialysis recently? For some of you that are business minded, you can set up a dialysis center. You don't even have to be a nephrologist to do that. Okay, so let's proceed. But we know that when you are doing renal replacement therapy, you want to retard the progression of kidney disease, mitigate the effects of the kidney disease, and then control the complications. Okay, so that's why you do renal replacement therapy, and we all know that. So when someone has a kidney disease, uh, there are so many things that could occur, and you need to read the topic on kidney disease to see a lot of things, both the causes, whatever it is. The fact is that you need to do a renal replacement therapy when the kidney has failed beyond a certain level. Okay, when we now say it is end stage, you definitely must, replace the kidney, and we try to delay the transplant as much as possible, to help the patient, because there's still chances of failure. Remember that this patient will have to be on so many drugs: mycophenolate, mofetil, steroids, a lot of immunosuppressants, cyclophosphamide, you know, and these all have their own side effects too that will come with, after this transplant. So the patient will start coming down with what do you call it, opportunistic infections due to the immunosuppression, and so many other issues as well. So you need to be careful before you do it. So let's proceed. So indications for chronic dialysis. There's a place where it is listed. Well, I want to. Indications. I've talked about these ones before. So indications for renal replacement. There is clinical, there's biochemical, and this is the one I want. So let's look at the clinical first. So there's encephalopathy. So someone is having uremic encephalopathy. You know, it makes sense, right? If someone is having uremic encephalopathy, you should definitely um, give them renal replacement therapy like dialysis, because there's no other way of removing the urea that is already causing problems with the brain, right? Except you do a dialysis at that point. And kidney transplant will still take time, so you must definitely do the dialysis. If not, the patient will cone and die. Okay, so then pulmonary edema gets to a level in CKD when the patient start having acute pulmonary edema, it start looking like heart failure. So at that point, it becomes refractory to even diuretics. You are using a lot of diuretics. You are using furosemide, you are giving torsemide, you are giving uh, hydrochlorothiazide. None is working. They are not really. There's even this one that they use for renal patients. This stronger one again, zimetolazone, right? So you are using all these things and it's still not working. You need to actually do a dialysis. Then persistent GI symptoms. Uremia can also cause like kind of peptic ulcer kind of symptoms. Okay. Then uremia as well can cause pericarditis. So it's very important for you to do um, hemodialysis when you start having the features of pericarditis. Then uncontrolled hypertension, right? Then bleeding diathesis. So the biochemicals is when you are now looking at it, looking at each electrolyte one by one. You can take potassium, you can take bicarbonate, you can take urea, you can take creatinine, you know. So each one you take to determine the value will determine what you are going to do. So if you have potassium that is more than 6.5, it means it's already severe hyperkalemia. Normal potassium should be 3.5 to 5.0. When you have between 5.0 to 5.5, we say it is what? Mild. When you have between 5.5 to 5 to 6.0, we say it is moderate, right? Then when you have above 6.0, we say it is severe. But even when it is severe, we still wait. When it is now above 6.5, okay, you is an indication for you to do hemodialysis, immediate, urgent, emergency hemodialysis, right? Because this could potentially be a problem. And when you do an ECG in a patient with hyperkalemia, if you see any changes, all those tall tinted T waves, widened QRS complex, prolonged PR interval, all those stuff that's features of hyperkalemia on ECG. If you see anyone, then you don't have to even wait before you do the hemodialysis, especially in places like Nigeria where like your snap of your finger does not actually snap his finger. Like if you say, I want to do this thing now, no, 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 there will be so many impediments that you may even find out that it's maybe tomorrow. In fact, if you do it tomorrow, it means you tried. You really tried. You really worked hard for that patient to do it tomorrow. So it means you need to actually do something to save this patient's life. Can anyone guess what you can do in this situation? Like you've seen ECG changes and patient has hyperkalemia. You know that you may not be able to do this. You need to do a hemodialysis, right? But you may not be able to do it within the given time. What will you do first? What will you give this patient that can at least help in the meantime? You know, and what exactly are you scared of? Because if you know what you are scared of, you will now know what you need to give to prevent that thing you are scared of from happening. Like, does anyone know? You guys should know now. You are senior men. But we talked about this thing when you are writing primaries. What are you scared of in this patient? Let's talk now. Let's contribute. Okay, yeah, you are scared of cardiac arrest. Yeah, you have a point. Yeah. So what will you now give if you are scared of cardiac arrest in this situation? In hyperkalemia, you're scared that the patient could, the heart could stop beating. What will you do? What will you give? You have a okay, yeah, yeah, calcium gluconate. Yeah, that's the first thing that you should give. The first thing you will give is calcium gluconate. Thank God I asked you because you know sometimes you may assume that people know stuff. It's calcium gluconate. That's the first thing that you will give. Okay, so you give calcium gluconate. That will stabilize the heart first before you now start giving. There are many things to give, including dextrose, insulin. Okay, you can give maybe 8 units of insulin together with 10% dextrose, 20% dextrose, right? Uh-huh. Then you can also give together with 10% dextrose. You can also give even a salbutamol inhaler, like patient can inhale salbutamol and it will still help. There's so many things to give. There are many lines. There's this potassium ion binding resins that you can also give, right? But the very first thing that you should give is 10 mils of 10% calcium gluconate over 10 minutes. And you can repeat it every 5 to 10 minutes, right? So the reason why you are giving it is that you are suspecting the patient has this stuff. You did an ECG, you saw ECG changes. So those ECG changes are already like a sinister finding, right? So if you don't do something, if you don't give something to stabilize the heart within some time, it could be something bad, something very bad could happen, and it will be terrible that you know about it, you saw it coming, and you didn't do anything about it, and that's the worst. That should be the worst fear of a doctor. Like you are seeing a patient, you know something is going to happen, you can see the signs, you can see everything, and you didn't do anything about it. That's terrible. So then bicarbonate that is less than 12 millimole per liter. What's the normal bicarbonate level? Because when you are trying to analyze it, try to for you to really remember stuff, you need to know the normal. Okay, then relate it to the one you are trying to remember. Okay, so what is the normal bicarbonate level, so that you now know if it is above, if it's below a certain level, you will conclude that the patient has um, okay. And we used to use 22 to 28 then. Okay, so this is like half of what the lower level should be, right? So less than 12. Then urea above 25 millimoles per liter, creatinine above 600 micromoles, you know. Then features of catabolism. So these are some of the indications. Just know there is clinical, there is biochemical. So clinical are basically the findings, the clinical features of uremia. Could be on the pericardium, it could be on the in the lungs where you have uh, acute pulmonary edema. Could be in the GI where you have gastritis. Could be in the brain where you have encephalopathy. Just think of it like that. So hemodialysis requirements for hemodialysis. We need a hemodialysis machine. Okay, we need a water purification system. Yeah, you need lots of water. If you have been to the renal unit, you know that you actually need lots and lots of water. Okay, to be able to run a proper hemodialysis machine. So you notice that the water is one of the reasons why they will tell you, okay, the nurses will tell you, okay, we are not able to do this dialysis. We don't have water. Okay, you will not be wondering why do you need so much water. They actually need so much water because the process of purifying the blood needs a lot of water. It's as if you are doing um what do you call it? You are passing stuff through the semi-permeable membrane. So you need a lot of water to actually draw the substance out, draw the is it the dirt now, the abnormal things that you don't want, okay, out of the blood. So dialyzer to cleanse the blood. Okay, so dialyzer is actually it's like the surface area. Okay, it's like stuff that those things will get, will pass through. It's like the semi-permeable membrane where those stuff, the waste products, urea, creatinine, and other waste products of metabolism, okay, where they are going to pass through is the dialyzer. Okay, then the dialysate solution, there's a particular solution called the dialysate. Okay, all these things are expensive. Then for each patient, you have to use a different dialyzer. You have to use a different dialysis solution. Okay, dialysis solution, you can be refilling it. Okay, but for each patient you are dialyzing, you need a new dialyzer, I think. Then vascular access usually surgically created by the vascular surgeons. Okay, who can be the cardiothoracic surgeons or people like that. They're the ones that usually create it. Then manpower, and when they create it, they give it time to mature before. So it means before you can't just get up and go and start doing uh, uh, um, hemodialysis. You need to plan for it. Okay, so when they create it, they need it to mature so that it will be useful for a long time. Though there is one that you can actually do as emergency. That's one they will just go and insert into the femoral artery. If you did renal postings in your house job or whatever, you may, or even as a registrar, you may have done that cannulation. It's quite tough to do, but it's one of the things that you would have done. Then manpower, you need nephrologists, you need surgeons, you need dialysis nurses, special kidney dialysis nurses, okay? Dietitians, yes, technicians, because you're working with machines, you need technicians. So let's look at the components of a hemodialysis circuit. So the main components are the hemodialysis machine itself, the water purification system, like I mentioned earlier, then the dialyzer, okay, is this thing that looks round, but I'm going to probably show you a video. This is what the setup looks like. Let's start from this is the patient, right? On the right, okay, and they have created a vascular access through the arm, connecting both the artery and the vein. So blood flows out through the veins, right? You use a what's this arterial pressure monitor to monitor the pressure that is coming from the blood vessel. You take it to the blood pump. Okay, the blood passes through the blood pump, which will now pump it, because you need pressure to it's as if you are filtering something. This is dialyzer. It looks like a box. Look, you can also see it here. It's just like a long box, a round long box. Okay, so you need pressure to push the blood. Okay, and that dialyzer is like a semi-permeable membrane, right? So when you push it with force, it will now filter itself. The dialyzer has a semi-permeable membrane that will absorb some substances, take them away, while the purified blood will now pass through the other means. Okay, and still in that dialyzer, that's where um saline solution will be entering there. Yeah, it's one of the things that are usually done. It's as if you are passing in normal saline into the blood as you are filtering it. Then the water purification system, whatever, will still be entering there. There will be a place for heparin, okay, because every blood that passes there, you don't want it to clot. So you give a lot of heparin to the patient, you know, outside the body anyway. So as the blood is passing outside the body, heparin is pumping in, and you're still measuring the pressure, okay, and everything is passing through the dialysate, and eventually uh, the fresh dialysate will now pass through another tube, okay, and that tube will have a venous pressure monitor. We'll have a monitor anyway to monitor that blood, and then check that there's no air that is trapped. Okay, every air that is passing through that tube will be removed by this air trapping mechanism. Okay, an air detection mechanism. Will remove the air, and then clean blood will now be returned back into the patient. Did you get this circuit? Are you guys following? Are you following? Okay. So yeah, that clean blood will now return back into the patient. But let me see if I can find a video so that just I like you to have a mental image. Okay, I hope this one will be useful.
Dialysis. Dialysis is a process through which waste products are artificially removed from the blood to compensate for the presence of an abnormally functioning kidney. In a healthy kidney, waste products, excess fluids, and electrolytes such as sodium and potassium are removed from the body in the form of urine. In the case of kidney disease, the loss of kidney function results in the increased accumulation of excess waste, toxins, or fluid in the body, thereby causing other complications such as hypertension, heart failure, pulmonary edema, metabolic acidosis, and hyperkalemia. Dialysis is performed in the
Can you see the video? The video is clear now.
following situations. 1. Acute kidney failure, or 2. To remove drugs or poisons from the body. Dialysis could be of two types. 1. Hemodialysis. 2. Peritoneal dialysis. Hemodialysis. This is done with the aid of a dialyzer, which is a machine present outside the body, which removes the toxic substances from the blood. A vascular access site is created by first numbing the area with local anesthesia and creating an arteriovenous graft by connecting one of the arteries with a vein with the help of a plastic tube, or an arteriovenous fistula by directly connecting one of the arteries with a vein. Once the graft or fistula has healed, hemodialysis could be performed for the patient. At the start of the process, Two needles are inserted into the fistula or graft, allowing a circuit to be set up with the dialyzer. Blood flows out of the body into the dialyzer, which consists of filtering fibers that remove waste products and excess fluid from the blood, and a dialysate, which acts as an absorbent solution for undesirable substances in the blood. Blood purified in this manner is returned to the body through the tubing into the second needle at the access site. When the hemodialysis session is complete, the needles and tubing are removed and the patient is allowed to return home. Peritoneal dialysis is done using the peritoneal lining of the abdomen, without the external removal of blood from the body. A soft catheter is first inserted into the abdomen, near the belly button, creating a port through which the dialysate can enter or leave the abdomen. Each session of the peritoneal dialysis is known as an exchange. The abdominal cavity is first filled with the dialysate, using the catheter for a period of time determined by the doctor. Through the peritoneal membrane, waste products and excess fluid are continuously drawn out of the blood into the dialysate, which ultimately drains into a disposable collection bag during the exchange.
Okay, so I believe that makes everything clear for you, right? So going back to what we were discussing, um, so that makes the whole system clear. Just know that you need a blood pump, you need monitors, arterial pressure monitors. Okay, you need a venous pressure monitor when it's returning back. You need something that will trap the air. You need a dialyzer. You need a dialysate. So if you can visualize this entire system, you need a water purification system. You need a heparin pump. Okay, if you can visualize this entire system, then anytime someone asks you a question on hemodialysis, you'll be able to answer it because you can see everything, even saline solution. Okay, so the procedure, we've already described it, and the video also described it further. And the process is by osmosis. Remember that osmosis that you learned in your chemistry class of the secondary school, right? Go and excavate it and bring it back, right? You know that osmosis basically has to do with substances passing across a semi-permeable membrane, okay, from region of which concentration? Is it higher to lower? So you now dust your osmosis book, dust it and refresh yourself. But just know that it's through the process of osmosis that this occurs, okay? And this time around, it will be an artificial membrane, which is what that dialyzer contains. Why the dialysate will provide the fluid, okay, that will actually absorb those substances, as we learned earlier. So, and it uses a countercurrent flow mechanism. Where else do we hear this countercurrent flow? It has to do with the kidney. Okay. So when we talk about countercurrent flow, we're also talking about the same process that happens in the kidneys. Okay, that's the countercurrent flow mechanism. So moving. So the dialysate is flowing in the opposite direction to the blood flow in the extracorporeal circuits. That's the meaning of countercurrent. So this one is going this way, the blood is going through this way, the dialysate is going through another way, right? And that will help to also improve that process of osmosis happening there through the semi-permeable membrane. So we move water purification system. Like I said, we need lots of water, lots of water. So any hospital that has a hemodialysis, you need to be pumping water actively, because one patient can use half of a tank to dialyze Then by the time you get the full tank, maybe two patients will use it, right? So you need to actively be pumping water. It's not the one of water don't finish, we no feed one. Okay, so let's work on that. And the water must be clean, right? Biochemically clean, microbiological microbiologically clean, okay, free from contamination, uses reverse osmosis, particulate filters, water softener, deionization, carbon filter. Okay, you can also look at this thing later, but it has to be an ultra pure water. Ultra, not just pure water, it's ultra pure, like very pure water. Should be used for hemodialysis. Less pure water may contribute to inflammation, and it's obvious because it's water that will come in contact with the patient's blood. So you need it to be free from microorganisms, free from abnormal electrolytes, just ultra pure water. Okay, at least once per year for chemical composition, you need to do water purification quality control just to check like the water that you're actually using for this hemodialysis is pure as you expect. It's ultra pure, not just pure, ultra pure, right? More regularly, depending on in parts on the mode of dialysis. Okay, dialyzer, we've mentioned it. Dialyzer may have different sizes, biocompatibility, and flux. So this is a sample of a dialyzer. Like I said, you use a different dialyzer for a different patient. You will not be using the same dialyzer for every patient. Do you get? So part of that money that they pay is for you to get. You already have the machine, you have the water system, you have heparin. Okay, you can also get new heparin, but you may not finish one, heparin for one patient. So, but let's just assume that you're getting a new heparin, you have water. Let's say you already have water, you already have the machine, patient has venous access. So the particular thing that you have the dialyzer, which is the liquid, okay, so that you can keep refilling for each procedure, right? You can use one when you buy it comes in gallons. You can use one for a long time, okay. But this one, this sorry, you can use the dialysate. That's the one that comes in gallons, the liquid. But this dialyzer, this one in particular, it's you have to use a different one. Like just imagine that you are doing cannulation for a patient, or you use a syringe for a patient. You now come and use the same syringe for another patient. You're transferring stuff from one patient to the other. So you need to get a different one for a different patient, because this is the actual thing that does the dialysis itself. This dialyzer, this round stuff you're seeing. And they can bring it for you in your OSCE, right? They'll just drop it there. So you should be able to know that it's a dialyzer. You can see how it looks like. Consists of a hollow fiber made of modified cellulose, has blood compartment and dialysate compartment, which makes sense. Blood will be passing through blood, and the dialysate will not be meeting. There's a membrane that is separating the blood from the dialysate, and then the dialysate will be flowing in an opposite direction. That's why it's called countercurrent flow. Why the blood will be flowing in the opposite direction, right? Then there's high flux, there's low flux, depending on, and that's why they say there's high flux dialysis, there's low flux hemodialysis. So, like patients that you want to, if you are doing a low flux, you have to, it will take longer time, right? To take a very long time. But if you are doing a high flux, it will take a shorter time to do it. But there are situations where you need low flux. For example, elderly patients, or maybe patients that maybe heart failure, patient with heart failure, you're not going to be doing a high flux hemodialysis, you do a low flux. Okay, so then for conventional dialysis, low flux membranes are suitable, but to achieve hemofiltration or hemodiafiltration, high flux membranes are necessary. So when you're getting a dialyzer, you need to take note of that. Then it comes in different sizes. Choice depends on the surface area and choice and size of dialyzer. So in adults, uh, desired dialysis dose and effectiveness determines the size, while in children, area will determine the size. So this is um, dialysis. These are some of the tubes that they use for cannulation. So when you get the dialyzer, you get the tubes that are used for cannulation. So some of them are single use, and there's reuse. Dialysis units reuse dialyzers to become more economic and reduce the high cost of single use dialysis, which can be extremely expensive and wasteful. Okay, then the dialysate is basically bicarbonate that is buffered and has other components. This is also a possible question. You need to know the components of the dialysate, okay? There's buffered bicarbonate, there's low calcium level, 1.25 millimoles per liter. There's dialysate quality control, okay, which where they will remove the germs and toxins. And it has to be potassium free, okay. No. The potassium free dialysate is rarely used because of the risk of hypokalemia. So they use the one that has some potassium, some calcium, that's low calcium, low potassium, uh, and buffered bicarbonate. So see here, sodium 140 millimole, which is like the mid-range of what you expect in the blood. Potassium 0 to 3 millimoles, depending on serum potassium concentration. Bicarbonate 35 millimoles. Calcium 1.25. Uh, Magnesium 0.5. So all these are the things that you are going to be seeing inside the dialysate solution, right? Then vascular access, there's a temporary vascular access, like I mentioned. If you want to do an emergency procedure, you go to the femoral artery. It's a temporary vascular access. Okay, but if you want a permanent one, you need to create that AV fistula. So fistulas, grafts. You saw the difference between the graft and the fistula in that video that I showed you. Then insertion techniques. I've already shown you. You don't need to bother yourself too much. Okay, just note some of the places where it is done. There's the tunneled, non-tunneled, right or left, jugular, subclavian, femoral vein, dual or single lumen. Okay, just you can read this stuff up. So when you want to make a choice of vascular access, you need to consider the patient's size, the surgeon's expertise, okay, interventional radiological expertise. Just all these are things that you need to consider before you know, patient's choice. Like if patient is considering how it is going to look, maybe the cosmetic appeal, swimming, pain, okay, and then the cost and availability in your environment. So KDIGO uh, guideline recommends that 50% of all end-stage renal disease patients should have AV fistula before starting hemodialysis. So it's actually recommended, and that's part of what you do when the patient is getting to stage 3B. You should be planning on citing an arteriovenous fistula because at some point you are going to need hemodialysis. So the sites, fistulas are usually created in the non-dominant arm. Okay, this is something to note. Non-dominant arm, which makes sense, right? You are not going to go because it's going to be disturbing the patient. Sometimes when they finish dialysis, the hand may even be dermatous, be swell up, may be painful, and all that. Okay, so you try to use the non-dominant hand so that they can be able to, perform their other activities. Uh, there's the forearm, radiocephalic fistula. There's the elbow, usually a brachiocephalic fistula. So the advantages of AV fistula, it has lower infection rates, okay, because you don't use any foreign material. Unlike AV grafts, there's AV grafts where you are using a foreign material to connect the artery and the vein. But in AV fistula, you're just connecting them and side to side, okay, side to side of an artery and a vein, okay. So high blood flow. When you do that, you allow it to mature, like I mentioned, and it has higher blood flow rates. So the AV fistula is actually preferred, okay. Lower infection rates, higher blood flow rates, which translates to more effective dialysis, and then lower incidence of thrombosis, which you don't want, right? So this is what it looks like a radiocephalic fistula. Everything is connected to the vein, but you are now connecting the artery to the vein. You connect the one that is going out to the vein, you connect the one that is coming in still to the vein. As a venous graft, like you saw in that video, you connect it, you put a tube that connects the artery and the vein. So this one you're using a synthetic material, which means there's risk, there's higher risk of thrombosis, there's higher risk of infections, okay, and it may not be as effective as the fistulas. You can also do a central venous catheter insertion, okay. Right-sided catheters are better than the left. So, and as a venous fistula can fail in as high as 33% of patients. Are you guys following so far? You raised your hand, Dr. Molala. Can you ask your question? So, can you unmute yourself and ask your question? I just permitted you, so you should be able to unmute yourself and ask your question. And see if I can finish this one, this hemodialysis. Okay, so you can read up some of these things. These are the tubes that I used. This is where they are clamped, you know. You can look it up. Later, you come and take a look at this video so that you have a better view. You can also go to the renal unit to see better for yourself. When you size the line, you flush it. You can use this place to cover it. It's like a clip. Okay. When it starts flowing, when you want to stop the dialysis and all that, it's something that you need to watch. So it should be individualized, but usually we recommend about two to three, 3 to 4 in some settings. Okay, 2 to 3 in some settings, depends on the patient's economic indices and the clinical state, right? So 2 to 3, 3 to 4 dialysis per week. That's how regular it should be done until the patient eventually has a what do you call it, renal transplant. So dialysis composition and flow rate. In general, flow rate should be about 500 mils per minute. Okay, that's what is used. Blood flow should be about 300 to 500 mils per minute. Anticoagulation, we use heparin, I mentioned earlier, unfractionated heparin. We use a dose of about 3 to 5,000 units diluted in saline and given throughout a session. Like you don't give it at once, but as the session proceeds, it's given outside the body, it's not inside the body. Oh. It's given outside the body, extracorporeal. So as that blood is passing through, somewhere along the line, that heparin is flowing as well at its own rate. So sections usually last about 3 to 4 hours, except if it's the low flux one. If it's the normal one, the high flux, 3 to 4 hours it should be done. Patient can even sleep, can do anything, can be eating granules while it is going on. Okay, and can be talking and gisting with you. But you need to monitor for complications. I think we need to get to that place. Uh, let me get to. Sometimes you may need more frequent sessions if patient is now deteriorating very fast. You need to read this note. Everything there, everything in this note is important. So I just want to make it easier for you to enter the note so that when you are reading it, you can easily grab what you need to grab. These are calculations. Let me look for the contraindications and the complications. So when you are done with renal transplant, you need to quickly check the serum electrolytes, urine, and creatinine again, so that you'll see what happened, right? You must have checked before you did the dialysis now. So when you are done, you check again to see, you know, the progress you've made and what exactly is going on. So complications of hemodialysis. There's the acute complication and there's chronic complication. So let's look at the acute complication. The things that you expect sharp, 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 sharp as soon as you are done with hemodialysis. There's this disequilibrium syndrome. Patient just finished hemodialysis, feeling dizzy, feeling lightheaded, tries to stand up, falls, feeling dizzy. Suspect is between hypotension and disequilibrium syndrome. Okay, so these are the things that you need to do. Give them normal saline. Okay, sharp, 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 sharp. Give them normal saline. Okay, to see, uh, how you can improve their life. If not, patient can pack. And embolism can also occur, hemolysis, infections, that's down, down, down. Arrhythmias, you know, I've seen a patient that had hemodialysis, started having developed arrhythmias. So that's something that can happen after a hemodialysis. And there is first use syndrome. So if patient has that first dialysis, patient body can react to it. Okay, these are all possible complications. Then the chronic ones, the ones that will take time to occur: anemia, bone disease, uremic neuropathy, uh, acquired cystic kidney disease, amyloidosis, pericarditis, malnutrition, skin disease, access failure. These are all complications. Okay, so hypotension is quite common. See now, 20 to 30%. So whenever you see a patient have the hemodialysis, he's telling you that he's feeling dizzy, tries to get up, falls, feeling lightheaded. Suspect hypotension, suspect disequilibrium syndrome. Okay, and some of them do have nausea and vomiting, muscle cramps, headaches, pruritus, fever and rigors. They wrote rare here, but I've seen many cases of disequilibrium syndrome. Okay, so you take note of it. These rare ones are the ones that can be very deadly when they do occur. The ELISA reactions can also occur, so you need to be sure the patient is not having allergies. Seizures can occur after this intracranial bleed. Other complications: hypertension, access related complications. So maintenance of hemodialysis, the machine is costly, and we know that trained personnel are not very sufficient. Uh, there are a lot of things, everything from water sef, water is not available, poor road communication, expensive procedure, inavailability of trained technicians, a lot of stuff. Okay, these are the challenges. Contraindications of hemodialysis: hemodynamic instability is a contraindication. Okay, arrhythmias, hypotension, anemia, lack of access. So you need to optimize the patient. That's why you can see that some patients, when they want to go for hemodialysis, you can give them intra dialysis transfusion. That's what they call it, right? So during the dialysis, you can give up to 2 to 3 units. Okay, so it's as if you are also dialyzing the blood that you are also giving the patient. So that's one of the things you can do. If the patient has anemia, instead of you to say, I'm not going to dialyze you because you have anemia, instead you source for the blood, get the blood, and give the patient as you're dialyzing the patient inside the intradialysis that you transfuse the patient. Hypotension, optimize the blood pressure. Anemia, okay. Uh, Hemodynamic instability, uh, you actually wary. So if patient has hemodynamic instability, that's usually a situation where you want to do low flux hemodialysis, very slow. It takes about almost 12 to 24 hours to complete. Very slow, okay? But if the patient doesn't have any hemodynamic instability, you give the bomber fire high flux hemodialysis, 3 to 4 hours, you are done. Okay, uh, so the next time we'll discuss peritoneal dialysis. I think I'll stop here. Do you have questions? I think I've been able to make this topic as simple and easy as possible, considering that it's quite can be a difficult topic to discuss. But I think you guys will enjoy, you know, the stuff. So, any questions for me at this point? Do you have questions? Dr. Kingsley, do you have questions? Dr. Kauta, Dr. Tega, Dr. Clinton, Dr. Omolola. Okay, Dr. Kauta doesn't have questions. Anybody with questions or comments or anything before we call it a day? All right, the next time we are going to be discussing peritoneal dialysis. I'm going to, once I end the live stream, I'll be able to, what do you call it? I'll be able to share the videos. I'll put it inside the app so that you can access it the same way that you have been accessing other videos. Okay, uh, so thank you. See you next time. Bye.